So this time what we're going to do is we're going to go over the life cycle of a T cell. So there are 5 major steps in the life of a T cell. Now, every T cell starts off life kind of like a college student, young and naive. So a naive T cell is a T cell that has never met its purpose in life. How many of you know seniors who are about to graduate and they're like, I have no idea what I'm going to do. I'm going to graduate, maybe I'll go back to, I don't know what I'm going to do. Nursing students usually don't have that problem because what are you going to do? Well, I'm going to go be a nurse. But, you know, and they got communications, you're like, I don't know, I'm going to communicate. So a lot of times college students don't really know what they're going to do because they haven't found their purpose in life. And what is the purpose of a T cell? You got nothing. Specific to what? An antigen. So what's its purpose? Its purpose is to find and bind to that antigen and to fight it no matter how it can. So our T cells start off life naive. Naive T cells circulate through the blood and the lymph, hanging out in little lymph lattes, or lymph cafes, sipping lattes, surfing the internet, texting their friends, waiting to find their purpose in life. Meanwhile, a dendritic cell comes along. I tasted something bad, and it goes up into the lymph node and it says, have you seen this antigen? Do you know this antigen? Do you know this antigen? And when a T cell comes along that recognizes the antigen, what happens? I know that antigen! And the dendritic cell says, kill it. I found my purpose. That is called recognition. So there's two parts to recognition. One is it has to recognize its antigen, but 2, it needs to be told a signal to kill that antigen. This is kind of a little bit of a safeguard. In the thymus gland university, if there's a T cell that attacks inappropriate things, the thymus gland is supposed to kill it so that it's not unleash damage upon your body. Like if it reacts to your own self-antigens, well, we can't have that, so let's kill it. If it reacts to something like, I don't know, food, well, that'd be pretty bad too, so let's kill it. But every now and then a T cell gets out that it shouldn't get out. So if it recognizes its antigen, but there's no dendritic cell to say, hey, kill it, it'll go and just float around the blood for the rest of its little life in a catatonic state. That's called anergy. So in order to be activated, it's got to have a recognition of its antigen and what's called co-stimulation at the same time. And what provides the co-stimulation? The dendritic cell. So that's step number 1, recognize. Step number 2, what can one little T cell do against all those big viruses and bacteria? Oh, you got to make more of them? Okay, so the fancy word for that is proliferate. The proliferation step is driven by a chemical called interleukin-2. That will come back to haunt us later, so anyway. Step number 3 is going to be differentiate. What does that mean? Differentiate is a fancy schmancy word to mean mature. So it is no longer going to be an immature, naive T cell. It is going to become a fully mature killing machine, or managing machine, as the case may be. So it'll become, it's fully developed either secret agent or manager. It'll also make the choice to become a type 1 or a type 2 if it's a manager. Then the last step is what's known as effector function or immune action. So if it's a secret agent, it's going to go out and secret agent. And if it's a manager, it's going to go out and manage its little heart out. Now, we've won the battle. We've fought back the evil viruses. And we have all these veteran T cells hanging around. We don't really need them. There's no VA system for the T cells. What are we going to do? Kill them? Really? That's how we treat our veterans? No, actually, fortunately, because you'd die if you didn't. But, so yes, we're going to kill most of them, but a few of them are going to stick around. They're not going to die. What are those ones that don't die called? Memory. Now, memory T cells are fully developed, ready to kill T cells. So the next time this same antigen comes around, we don't need to do steps 1, 2, 3. All we need to do is proliferate and then effector function. We don't have to wait for recognition. Does that make sense? All right, so that's how a T cell goes. Now let's talk about how B cells are a little bit different. Now, B cells don't get a choice in life because they didn't go to college, so they have to stay home and get factory jobs. Well, it's not exactly true. They don't get factory jobs, they become factories. They actually become little factories that make what? Antibodies. So, B cells produce antibodies. Now, they go through a very, very similar process, but it's ever so slightly different. So under recognition for T cell, what is it that provides the co-stimulation for a T cell? A dendritic cell. What presents the antigen in the first place? That's what it uses to inspect cells. But in order to recognize what cell presents it? Dendritic cells. So a dendritic cell provides the co-stimulation and does the presenting. Now, with a B cell, it's a little bit different. So let's imagine for a moment that we have our little viral cell here, multivalent. And here we have our giant B cell. Now, this B cell recognizes ears. So if it binds to an ear, what's it going to do? You don't know? Stop. Freeze. Don't do anything. Is that what it's going to do, or is it going to do something? It's probably going to do something. All right, so what it's going to do, it's going to stick to it, and it's going to pull the whole thing inside. So now here you've got, by the way, this is actually an antibody that's stuck out of the membrane. It's called a membrane antibody, IgM. By the way, we haven't mentioned the word Ig yet. What does Ig stand for? Immunoglobulin. Globulin is a kind of a protein, and immuno because it's immune action. So this particular kind of antibody is called IgM because it's sticking out of the B cell's membrane. So we suck the IgM antibody inside with our little virus attached. And now it's going to digest the virus. It's going to chop it up into little pieces, and then it's going to display it on the outside. So we've got little triangle ears there, we got little eyes there, and we got little noses there. So how many types of antigens are sticking out of this thing now? 3. Now, B cells and macrophages have a different kind of MHC. They don't have MHC1, well they do, but they also have MHC2. And MHC2 is what your T cells use to bind and inspect. And, we forgot to mention, their badge is called CD4. So the CD4 membrane protein binds to MHC2 and allows the T cell to inspect it. Now, what if there were no T cell in your body that can recognize ears, what would happen? Can we never produce antibodies against ears? Or do you think there's a way? How many of you have seen Jurassic Park? Nature will find a way. So there's a way for us still to activate this B cell. And as it turns out, a T cell that recognizes noses can activate this B cell. A T cell that recognizes eyes can activate this T cell, and one that recognizes ears. So there's 3 potential different kinds of T cells that can activate that one B cell. Does that increase the chances that that B cell will be activated? Does it increase the speed in which it will probably be activated? So this little process where it sucks it in, chops it up, and now multiple T cells can activate it is called linked recognition. So linked recognition is different than T cell recognition in 2 ways. What are the 2 ways? First of all, what does the presenting? In the case of a T cell, another cell presents the antigen. In the case of the B cell itself presents the antigen to what? A helper T cell. What does the activating in the B cell's case, in linked recognition? The T cell. So in a T cell recognition, the T cell is being asked, do you recognize this? Yes, I do. Okay, kill it. In the B cell is saying, hey, I want to kill this thing here. Do you recognize any of these? If you do, I can kill it. Does that make sense? So it's a little bit different, but similar. Now, the next 2 steps, proliferation and differentiation, are a little bit different for a B cell. Is there anyone in here who's good at drawing? Anyone? One person? How do you typically draw something? Do you just start off and like draw it? Or do you start off with like a little sketch that doesn't have a lot of detail, and then you fill in some details, then you shade it, and then you add in some highlights? Which of those 2 processes do you think is more common? What? Second one. So you start with a little sketch. Sometimes the sketch doesn't even look like anything. I remember when I was a little kid, I wanted to learn how to draw horses. So I got a book on how to draw horses. You know what it has you do? It has you draw circles. Does that look like a horse to you? Well, now you connect the circles. Does that look like a horse to you? Oh, I got to draw another. And then you erase the circles. Now you have the outline of a horse, right? Okay. So as you go along, it looks more and more like a horse. Now, this is important because the very first antibody produced, what's it called? What was that antibody that sticks out of the membrane called? That is complement cascade. IgM, M for membrane. So that very first IgM is a very low quality antibody. It doesn't stick very well to antigens. What's that theory that we think that they use to stick? Was it? Lock and key. So imagine for a moment that the surface of the epitope looked like this. Okay. And maybe our very first antibody, the receptor portion of it looks like this. Did that wrong. Looks like this. So can it stick to that part right there? But does it stick to the rest? So it's not very sticky. What if we had one that looked like this? Would that be more sticky? What if we had one that looked like that? Would that be even more sticky? And then what if we added in a piece that looks like that? Even stickier, right? So every time we add a little bit of detail, we increase its ability to bind to that epitope. That ability to bind is called affinity. So IgM is low quality, low affinity. So what are little T cells going to do? Here's the B cell, here's the T cell. So B cell, T cell. The T cell is going to go, okay, B cell, divide. So it's going to go, okay. All right, we've divided, now what? All right, you up top, I want you to start producing antibody. I know it's crappy, but it's better than nothing. You three, let's see what you got. Mutate and see if you can do better. And then it goes, you suck, you suck. All right, you're okay. You replicate again. All right, mutate. Let's see what you got. Die, die, die. You're okay. All right, mutate again. All right, yours is terrible, yours is terrible, yours is terrible. Hey, you're pretty good. Let's use yours. Does that make sense? So, very early on, we've allowed some to produce low quality IgM. And then we've done this mutating process to get good quality, high affinity antibodies. And that is called maturation, affinity maturation. So steps 2 and 3 are a little bit kind of linked together in the case of a B cell. And what is directing that affinity maturation process? The T cell. So the T cell is directing this process. Does that make sense? All right. Now, at the end of maturation process, affinity maturation, there's going to be something called isotype switching. So there's 5 different types of antibodies: IgM, IgD, which anytime we don't know what something does, we say it has no purpose. So IgD has no purpose. What does that really mean? It might have one, but we don't know what it is, so it's worthless. IgG, IgA, and IgE. So let's talk about each of those real quick like. IgG, IgA, and IgE. All right. IgG is very, very good at neutralizing and opsonizing. I guess I should tell you what the four functions of an antibody. First one is neutralize. What does that mean? Close. Imagine for a moment that someone's trying to assassinate the president. What would all of the Secret Service people do? Well, they protect the president and then they grab the guy, right? So imagine for a moment someone had a knife. How would you make sure that the knife can't hurt someone? Everyone grabs his hand, right? Right? Grab him, grab the guy, give him a noogie, and then neutralize him. So when they bind to the antigen, so it can't harm something, that's called neutralize. Opsonize, what's that? Anyone? Bueller? Bueller? You've never seen Ferris Bueller's Day Off either, have you? Okay. So, what is opsonize? Look back under complement cascade. It's painting the cell for destruction by a macrophage. So, the First one is neutralize. Yeah, we're running out of room. So neutralize. Second one was opsonize. Third one is activate complement. And the fourth one, complement, and the fourth one is increase inflammation. All right, now IgG is incredibly good at neutralizing and opsonizing. Type 1 helper T cells are very good at producing high affinity IgG because it helps macrophages. So, type 1 promotes IgG. Type 2 promotes IgE, which has an enormous inflammatory response because IgE, remember, inserts itself into eosinophils and mast cells. When an epitope activates that IgE inside the mast cell or eosinophil membrane, it causes that cell to degranulate, causing an enormous amount of inflammatory reaction. Does that make sense? So IgE is really good at increasing inflammation. IgA has a special property, which you get two antibodies that are stuck together. Now, if you take a molecule and you stick it, a whole bunch of them together, what do you call that? A whole bunch of exactly the same molecule stuck together, what do we call that? What's the Greek or Latin for many? Not multi, the P one. Poly. And it's a molecule, so it's a polymer. You may have heard that term sometime in the past. Now, when there's just two molecules stuck together, what's the Greek for two? Dimer. So this is called a dimer. And it has the special ability that it can cross membranes. So it can cross into your eyes, it can cross into your stomach, it can cross into your lungs, and it can cross through the placenta, maybe not the placenta, it can cross through breast milk. So little baby can get antibodies from his or her mother. So the purpose of IgA is to cross membranes. So what's the purpose of IgG? Neutralize, opsonize, helps macrophages. Stimulated by what kind of helper cells? T helper 1 cells. IgE, really good at producing inflammation because it attaches to eosinophils and mast cells. And the production of IgE is stimulated by what kind of helper cells? Type 2 helper cells. And then IgA has a special purpose, and what does it do? It forms dimers which can cross membranes. All right, so we've got four functions. We've got 3 types plus IgM over here. IgM is crappy. What's its purpose? Something's better than nothing. At the end of this affinity maturation process, what do we get? One or more of high quality antibodies. Each has their own unique function. Now, on the test, when I say list the 4 functions of antibodies, that doesn't mean list the 4 types of antibodies. What does it mean? List the functions. If I want to know the types, then I would say list the types of antibodies. So make sure you read the question carefully. Because if you answer the wrong way, I'm not going to go, oh, you're so smart. I'm going to go, you don't know the answer. That's why you're just writing whatever. All right. The effector function is the same, except instead of agenting or helping, it's going to antibodies, right. And then once the infection is gone, most of them commit apoptosis, and the ones that are left over become memory cells. All right. Now, let's put this all together.
Four types of cells with IGs.
Say that again?
You said no difference between four types of cells and type.
If I said cells, I meant 4 types of antibodies.
So 4 types of antibodies.
Yeah. You need to know the 4 types of antibodies, and you need to know the 4 functions of antibodies.
But the types of IGs.
Yes.
Okay.
Yeah. So for those of you who can't hear in the microphone, the question was, so those are the IGs? Yes. IgM, IgE, IgD, IgG, and IgA. All right, so now what we're going to do is we're going to draw some connections. So over here we have immunity, which is specific. Over here we have inflammation, which is non-specific. Now, what starts the specific? A dendritic cell. So a dendritic cell is going to come over here and activate a T cell, right? T cells are going to then in turn manage macrophages, and they're also going to manage B cells. I erased that by accident. B cells are going to produce antibodies, which in turn help direct macrophages and help activate complement cascade. And the complement cascade then helps macrophages do its job better. You need me to move aside so you can take a picture? It's a masterpiece, isn't it? Yeah. It's beautiful. I'm not done yet. All right. Now, we got to talk a little bit more about B cells and antibodies before we're done. So, a fully mature B cell that is ready for effector function has a special name, and that special name is plasma cell. Someone want to move around so we can have our light back, or whatever. So, what is a plasma cell? A fully mature B cell. So when a memory cell happens, when it survives the apoptosis culling, what is that called? What is a memory cell technically? A plasma cell. Plasma cells are important for a number of reasons. They're the reason why immunizations work. Now, there's 2 different types of immunizations, passive and active. What do you think is happening in active? Not necessarily. Could be, but not necessarily. What is your body doing actively? When you receive an immunization, what's the goal of the immunization? To make antibodies. So your body will actively make antibodies. How long does an active immunization last? Well, it depends on the individual immunization, but in the case of something like measles, how long does it last? 15 years? In the case of hepatitis B, how long does that last? 20 years? In the case of tetanus, how long does that last? 5 to 10 years? 10 as long as you don't hurt yourself. Then it's only 5. Okay. So in the case of flu vaccine, less than a year. So it depends, but it's a relatively long period of time, up to years, decades even. Passive, on the other hand, is where you're receiving preformed antibodies. Someone else made the antibodies, and now we're giving them to you. How long do those antibodies last? A couple weeks, tops 6 weeks. Now, what is the advantage of active immunization? It lasts a long time. What's the advantage of, but what's the downside? How long does it take to happen? Yeah. So it can take a while. It can take up to 6 months sometimes before you get really protected. What's the advantage of passive? How long does it take for them to start working? Immediate. What's the downside? Doesn't last very long. And it also hurts like heck. So if you're bitten by a rabid animal, when would you get rabies? About 2 weeks from now. When would the active rabies vaccine start working? About 6 weeks from now. So you're dead before it works. So if you're bitten by a rabid animal, we need to give you preformed antibodies. What if you're bitten by a rattlesnake? When does the poison start working? Right now, immediately. So if we gave you an immunization against it, it wouldn't really help. But what if we could give you preformed antibodies? Have you ever watched the rattlesnake show on Animal Planet or Discovery, whatever it is? What do they do with those rattlesnakes? They go in the desert and they catch them, and then what? They milk their venom, and then they take the venom and what? They inject it into innocent horses. Why a horse? Because they're big and strong. They can take it. And then what does the horse do when it gets venom injected into it? Produces antibodies. Now we take the horse plasma, separate out the plasma, and what do you get? Antibodies, anti-venom, that we can then give to a patient who was unfortunate enough to get bitten by a rattlesnake. Well, most people who are bitten by rattlesnakes are what gender or what sex? Men. And they're usually bitten on the hands. What does that tell you? They're trying to, yeah. So that's why I say stupid, not unfortunate. Anyway, so second most common place is on your foot because you step on it or step close to it. That's unfortunate. On the hands, that's just stupid. But anyway, so that's what passive are. Now, all of the immunizations that we typically think of, measles, mumps, rubella, flu, hepatitis A, hepatitis B, pneumovax virus, varicella, all of those are what kind of immunization? They're all active. Are you going to get this wrong on the test? Or are you going to get it right on the test? Oh, I'm getting it wrong, Dr. Heyman. Telling you right now, I want to be wrong. So most of them are active. What is the purpose of them? To induce your body to make antibodies. Okay. Then we have to talk one last thing is called a toxoid vaccine. So imagine for a moment that there's a bacteria that produces a toxin that looks kind of like, well, it's supposed to be a dagger. Not a very good dagger, but okay. So what would this part of the dagger be? The handle. What would this be? The blade. And now, to quote another movie you probably haven't seen, do you know how the thing works? Yes, the pointy end goes into the other man. So, what part of this hurts the person? The pointy end. So, what if we produce a chemical that had no pointy end? It was all handle. Would it be dangerous? No. But if we made antibodies against this, when you got infected with the real thing, you would have antibodies that attack this and they would neutralize it before it could really cause any problems. Does that sound like a good idea? Okay, so this little portion without the damaging end is called a toxoid. And the most common use of toxoid vaccine is in tetanus. So when you get a tetanus vaccine, you're not being injected with dead bacteria. You're being injected with harmless toxin. Does that make sense? All right, that is it for immunizations for the moment. We'll talk more about immunizations in other places. But all right, next we've got a few things I'm like, where do we go from here? There's like several places we can go. So let's put them down. I'll let you choose which one you want to do next, within reason. All right, so one thing we have to do is wound healing. That'll be last. You get no choice on that one, sorry. We've got to do some drugs sometime in here. And we need to do tests, like inflammation or immune tests. And we also have to do hypersensitivity reactions or allergies. Same diff. Tivity. All right, which one do you want to do first?
Are we doing all of them?
Yep.
Hypersensitivity.
Hypersensitivity for $400. All right, so a hypersensitivity reaction is an allergic reaction. Now, we already talked about allergic reactions in Unit 1 of this course, and what is the definition of allergic reaction? An inappropriate immune response. And as it turns out, there are at least 4 mechanisms that we know of, and those are termed hypersensitivity reactions. And conveniently, they are numbered 1 through 4. But they also have names. And so for the test, you need to know the number, the name, the mechanism, and at least one example. Think you can handle that? No. So type 1 reactions are also called vasoactive. They have 3 names actually. Anaphylactic type and histaminergic. Whew. Now, they're called vasoactive because, well, they're called histaminergic because the major mediating inflammatory mediator is called histamine. Histamine causes vasodilation, which is why they're called vasoactive. And its most severe form, it can actually cause anaphylactic shock, which is why it's called anaphylactic type. Any questions there? So the mechanism, you produce IgE antibodies. Those insert themselves into eosinophils and mast cells. When the IgE is stimulated by its antigen, it causes the mast cell and the eosinophil to degranulate, releasing large numbers of inflammatory mediators, the number 1 of which is histamine. That in turn is going to cause swelling, itching, and other inflammatory problems. So in its most severe form, it can cause anaphylaxis. Some examples would include bee stings, um, 10% of food allergies. But these are the food allergies that are dramatic. So if you've ever seen the movie Hitch, we've already established that you should watch the movie Hitch. When his face swells up from eating shrimp, that's type 1 allergic allergy. The reason why when you went to school you probably weren't allowed to bring peanut butter sandwiches anymore, which is kind of silly, is because there are some people who are so allergic to peanuts that if they eat it by accident, or if they're like, here, let's trade sandwiches, they can die from an anaphylactic reaction. So that when I say dramatic food allergies, we're talking about the ones that will make you swell up, you get rash all over your body, or you die. Does that make sense? Okay. Asthma is also an example of this, and nasal allergies. So if you have like seasonal allergies, or if you're allergic to dust or mold where your nose gets all inflamed and you can't breathe, that's also the same type of allergic reaction. Any questions about type 1? All right, type 2 is called cytotoxic. And what you get is antibodies that are produced against your own body. Now, this one has been kind of a disappearing category. And the reason that it's been disappearing is that in order to get an antibody, you first have to have some other kind of immune reaction first, right? Like a T cell. So what we're doing is we're beginning to shift things out of this category into another category that's T cells. So if you listen to the very, very old podcasts that I made, I give some examples of things there that would be considered type 2 that were no longer considered type 2. So really probably the only one I can say for certain is type 2 only is would be considered like transfusion reaction. So if you get the wrong blood type, the antibodies against that blood is what causes the reaction. Another example would be if a mother is Rh negative and her child is Rh positive, that reaction would be a type 2 reaction. All right, next we have type 3 reactions. This is called immune complex. So what we're going to get is we're going to get an antibody and an antigen stuck together. And what is one of the purposes of antibodies? If you don't remember one, what's all four? Yeah, let's go all four. Neutralize, oxidize, activate, complement, and increase inflammation. So, wait a minute, complex. I've heard that word before. Where did you hear it before? Antibody antigen complex, which is one of the classical pathways to activate complement. So what happens is you have an antibody antigen complex that activates complement. And the complement cascade causes a large amount of inflammation, and that inflammation begins to damage the body. So inflammation is supposed to be helping, but in this case it's hurting. What's it called when you try and hurt someone, but you hurt someone else instead? What's that called? It's a military term. Collateral damage. How many have ever been next to someone who's fighting? Like maybe you had brothers and you're in the car and they're hitting each other and one of them moves and they hit you instead. Collateral damage. Okay, so the complement cascade is not trying to damage your body. It's trying to damage this immune complex, but the inflammation hurts you. One of those examples of that is rheumatic fever, which we talked about with strep throat. So the antibodies that attack the Streptococcus bacteria end up causing the activation of complement cascade, which in turn is what causes all those other problems. So that Streptococcus bacteria can stick to the inside of your heart, the endocardium, and to the valves. And then when the complement cascade comes along and causes inflammation there, it can destroy the valve. It can do the same thing with your kidneys, causing something that's called post-streptococcal acute glomerulonephritis, which can lead to acute kidney failure. So that would be one example of immune complex. So it's complement cascade. So some examples here would include acute rheumatic fever, Stevens-Johnson syndrome, which we talked about for antibiotics, and also 90% of food allergies. Celiac disease. There's a whole bunch of them that are caused by this immune complex. Now, here's a fun little story. What if you're so allergic to a food that you could die from an anaphylactic reaction? What is one possible treatment? allergy shots. Well, how do allergy shots work? What do they do? They actually give you tiny amounts of the antigen. Wait a minute. To treat your allergy, they give you the antigen that causes the allergy, Dr. Heyman? Yep. Does that make you less allergic? Nope. But what happens is, hopefully, you switch from type 2, which produce IgE, to type 1, which produce IgG. And so that switches you from a type 1 reaction, which could kill you, to a type 2 or type 3 reaction where you just kind of feel bad. Most food allergies, they don't necessarily know they have it. They just know, like, when I eat certain foods, I just don't feel right. My stomach's upset. Ugh. They don't realize, oh, I actually have an allergy against that food. Does that make sense? Okay. The last kind is type 4, and this is called cell-mediated. Now, anytime you hear the word cell-mediated, the first thing should pop into your head is T cells. So T cells are directing an attack against your own body or against something that causes a reaction in your body. So an example of this would be contact dermatitis. Is anyone here allergic to latex? Well, if you were, that would be contact dermatitis. The latex causes T cells to attack it in your skin, and that causes an inflammatory reaction on your skin. Anyone here allergic to cheap jewelry? Yeah, so when you wear cheap jewelry, you get inflamed in that area, and the reason for that is T cells are attacking that base metal in the cheap jewelry, which is then causing inflammation in your skin. Another example is the transplant rejection. Type 2 diabetes mellitus and myasthenia gravis. Like how I can write 2 lines at the same time? Did you notice that? No? No, we're too busy writing ourselves, Dr. Heyman. So, anyway, so these are some common examples of type 4. Any questions about that? All right, let's talk about tests. So how does a person know they have inflammation in the first place? Well, you've got your 4 classic signs and symptoms, Dr. Heyman. Okay, how else could you know? Have we already talked about a lab value that you can check and see if it's high, then that means you have inflammation? Mm-hmm. What was it? Okay, well, white blood cell count by itself could be a sign. The most common cause of white blood cell count being elevated is infection, but it's not always. It can sometimes be a sign of an autoimmune disease or other immune issues. So that's not always infection, but the most common. What else? Okay, neutrophils and bands, sure. But I was actually meaning something else. We kept using this non-specific word. It's not infection, it's inflammation. What lab value was it? It was written right here, in fact. Earlier, this very lecture. But you see, Dr. Heyman, that was before we took a break. And when we took the break, when we flushed, all the knowledge went down along with the water. It was one of the classical pathways of activating complement cascade. And it wasn't the first or the third.
Highly sensitive CRP.
Well, CRP. Yeah. What's the purpose of highly sensitive CRP? Detecting arterial inflammation. So, but for just ordinary, do you have inflammation or not, you can check CRP levels. So that would be another example. Another one would be fever. And you can also check IgM and IgG levels. Now this one's a little bit important. Which of those is produced first, IgM or IgG? IgM. So during an infection, IgM levels go up pretty fast. Because remember, something is better than nothing, right? But then, as the IgG takes over, what you're going to see is it's going to look like this. And this is your IgG levels. Now, how many of you got the varicella vaccine? And how many of you got chickenpox? Now, how do we know that you're immune to chickenpox?
You have to check your blood. So
You check your blood for what?
Resistance.
Not resistance, for immunity. What provides that immunity? Okay. All right, well, let's hold on for a second there. All right, so you had an infection, you fought it off, and then what happened?
Oh, the memory cells.
Memory cells. All right, so what would a memory B cell do? A plasma cell. What would it produce? Antibodies. And what kind of antibodies would it produce? Crappy low affinity or good high affinity? And what's the good high affinity called? I'll give you a hint. It's on the board right now.
Oh, the IgG.
IgG. So when we want to know whether a vaccine works or whether you are immune from having had an infection, we look at IgG levels. If a person has an infection and you want to know, is this an acute infection, is this a new onset, or have they had this for a while, you can look at the ratio of IgM to IgG. If IgM is high and IgG is low, what does that tell you? If IgM is high and IgG is low, what does it tell you about the time? It's a relatively new infection. If IgM is really low and IgG is high, what does that tell you? The exposure has gone on for a while, or their immunization worked. Does that make sense? Now, here's a fun little story for you. Most people nowadays are getting their hepatitis B vaccine when they are babies. The reason behind that is not pertinent to today. When we get to healthcare policy, we'll talk about that. But what we've been beginning to find is that it only gives you immunity for about 20-ish years. And that's just in time for you to do what right now? Go to nursing school. Why do we make you get a Hep B vaccine in the first place? Does it protect your patient? Or is it to protect, oh crap, it's to protect you. What does that mean is that the moment where now you need it the most is the time where it's beginning to go down. So in the future, we might be requiring titers or IgG levels on everyone. Because if they're down here, well, they might not be immune anymore. And so what would you need at that point? Another immunization. So you need a booster to go back up again. That's one of the fun things we've been learning over the years. So IgM and IgG is another thing we can use. And there's something else that we need to look at that's called, oh, by the way, when you look at IgM and IgG, you're looking at specific IgM and IgG. So it's the IgG against a particular antigen. It's not all IgG in your entire body. Does that make sense? Okay. So next we have something called ESR, erythrocyte sedimentation rate, also known as sed rate. Now what does the word sedimentation mean? Well, we'll start with the easy one. What is an erythrocyte? It's a red blood cell. What is sedimentation?
Shaggy layers.
How many have ever been to the beach? If you go in the shallow water where the waves are breaking and you get some of the water, is there sand in that water? Is there sand floating in the water where the water is like turgid and right where the water breaks? Yeah, there's sand in the water. And then if you hold that glass of water, what will happen to the sand? It'll settle to the bottom. What's that called? Sedimentation. So sedimentation is when particles drop to the bottom. So red blood cells, are those particles? Yeah, they're small particles, but they're particles. And if you leave blood alone, what will happen? They'll settle to the bottom. So if you measure how long that takes, that is called erythrocyte sedimentation rate. How long does it take for red blood cells to settle to the bottom? During inflammation, there are some products that are produced that cause red blood cells to stick together. So a heavier particle sinks faster than a smaller particle. Does that make sense? So those larger particles settle faster, meaning that the rate is faster. So an elevated ESR is a sign of? No! Inflammation. Now, one day, you kids are going to stop saying infection, you're just going to say inflammation. Hopefully that day is on the test. So ESR is a sign of inflammation, but not necessarily infection. So it's what word?
Inflammation.
I know, the descriptive term. Ashley? What descriptive term? Non-specific. What? Yeah. So, non-specific. There are some other things you can also measure. For example, if you're looking for autoimmune diseases, you can check what's called anti-nuclear antibodies, which are very common in some autoimmune diseases. And you could also look for RF factor, rheumatoid factor, which is common in rheumatoid type diseases. So there's a bunch of different things you can learn besides that, but these are some of the big ones that you really need to be aware of when you go to the hospital. You'll often see them look at ESR rates, CRP levels, and immunoglobulins. Any questions about the tests? All right, now we're coming to my favorite part, drugs. Love drugs. All right, so let's start at the very beginning. What are the 5 steps of the 5 stages of a T cell's life cycle? Recognition, proliferation, differentiation, effector function, and memory. What was number 2? Proliferation. And what chemical drives it? Conveniently enough, it's interleukin what? 2. So in order to make new T cells, and this doesn't matter whether it's naive T cells that have never been recognized or whether you're proliferating already developed memory cells. It doesn't matter. You need interleukin 2. Without interleukin 2, you can't proliferate. Does that make sense? Now, if we had someone who has an inappropriate immune response and we want to lower the immune response by lowering the amount of T cells, what would we do? We'd want to reduce the amount of interleukin 2, right? Well, as it turns out, interleukin 2 comes from a substance called calcineurin. It's a precursor to interleukin 2. And we have drugs that inhibit the production of this thing. That is not spelled right. Calcineurin. Yeah, who cares? Calcineurin? I call it calcineurin, but it's not really urine. It's, who cares? So, we have several drugs that can inhibit calcineurin. And by doing that, they inhibit the amount of interleukin-2, which in turn decreases the amount of T cells that are available for immune reaction. The two drugs that you need to know that do that, the first one is the older drug, is called cyclosporin. And the newer drug, which is still 20 years old at this point, is called tacrolimus. So these drugs are primarily used to treat or prevent transplant rejection, and also used to treat autoimmune diseases. So what is the first autoimmune disease we learned about in this class? Myasthenia gravis. You could use one of those drugs to treat that. Now, because these drugs target T cells, you can also use them for any of your T cell mediated hypersensitivity reactions. So if you take tacrolimus, put it into an ointment and spread it on your skin, you can use that to treat contact dermatitis. So it's kind of weird that the same thing you use to treat poison ivy rash also prevents transplant rejection. But hey, whatever works. By the way, I didn't mention earlier, but poison ivy is a contact dermatitis that's T cell driven. And there's a certain number of people who, for whatever reason, their T cells just don't react against poison ivy. So they can rub it on themselves all day and they won't get a problem. Whereas most of us, you just look at it and you get a rash. By the way, never burn poison ivy. The poison is in an oil that is lighter than air and will float on the smoke molecules and get in your eyes. And now you've got poison ivy dermatitis in your eyes. Don't do it. And then it's all over your body. Yeah. And you can spread poison ivy by rubbing and by scratching. So it's just horrifically nasty stuff. Just say no to poison ivy. Anyway, so another drug is called pimecrolimus. You don't even know this for your test, but pimecrolimus is available in a cream form called Elidel, which some of you may have taken at one point for a rash. As far as adverse effects go, the number one adverse effect is going to be low T cell count, which is going to lead to lower immune function. Lower immune function puts a person at risk for what? Infections. It reduces inflammation, but inflammation is part of what helps fight infections. So a patient who's on one of these drugs is at increased risk for infection. There's a number of other adverse effects. Cyclosporin in particular can cause increased fluid retention, and there's a bunch of other stuff. You can read about it. The number one, of course, is increased risk for infection. Next, we have drugs that are called cytotoxic drugs. And these drugs, the way that they work is by inhibiting all fast-growing cells. And if you need to mount a new immune response, what would be fast-growing cells? T cells, plasma cells, neutrophils, all of those would be fast-growing cells. Now, one of the downsides is that they can also target other fast-growing cells in your body, like hair follicles, skin, epithelial cells in your mouth. So some of the adverse effects relate to hair loss, skin erosion, and sores in the mouth. Potentially bleeding, because platelets also need to be produced quickly. And what's the number one adverse effect, though, from a drug that inhibits the immune system? Risk for infection. So it's some drugs that do this. The one on your list is azathioprine. And I'll give you two more for fun. Mercaptopurine and methotrexate. Methotrexate is interesting because not only does it target fast-growing cells in your immune system, it also targets fast-growing cells that are called cancer cells. So it's actually a chemotherapy as well as an immunosuppressant. Pretty cool, huh? You don't seem thoroughly impressed, but you should be. All right, Next, we're going to talk about, oh, sorry. I don't even remember what was on here anymore. Azathioprine. Yeah, it's on the list. It's on the slides. Okay, so the next type of drugs we're going to talk about are called biologics. Now, these are relatively new. They're anywhere from 10 years old to like last year. And these are a new style of drug. And the concept is not that new. The concept goes back at least 20, 25 years. But these drugs being used in this way is relatively new. And what they are is they are antibodies that are produced against portions of your body's immune system. The number one target for the antibody is TNF alpha. When I say number one, the majority of the drugs target TNF alpha. But there are some other drugs that target other things. All biologics end in MAB, which stands for monoclonal antibody. What does monoclonal mean? Mono meaning clonal, meaning clone. So they're cloned against one specific antigen. The specific antigen in most of the cases is TNF alpha. Okay, so the only drug that I'm going to make you memorize, and so what's interesting is MABs have uses beyond just autoimmune, but the number one use for them right now is autoimmune. If you guys watch TV at all, start looking up the drugs that are on TV, and you'll find that a large number of them are monoclonal antibodies aimed against people who have, or targeted, advertising toward people who have psoriasis, which is an autoimmune disease that causes scaling and itching of the skin. So the one that you guys need to remember is, I can never remember its generic name, it's adalimumab. Humira is the brand. So that's the one we're remembering is Humira. On the test, I'll put both, but for the NCLEX, it'd be better. Well, if you recognize it's a MAB, you know it's a monoclonal antibody. So the number one adverse effect is going to be, what do you think it is? Increased risk for infection. So that's biologics. Again, this is a relatively new class. It's an exploding class. There's like dozens of them now, but I'm only expecting us to learn one right now just because, we've already learned so many. What's one more? No, okay, only one, and that's going to be Humira. Next, we're going to talk about antihistamines. Histamines. Now, antihistamines are typically divided into two categories, first and second generation. So first generation are older, second generation are newer. The first generation typically have more adverse effects. And the number one adverse effect you have to be aware of is drowsiness. And the number two adverse effects you need to be aware of is anticholinergic. So I think I've boiled down for the test, you only need to remember one, which is diphenhydramine, which is better known by its brand name, Benadryl. So you can give Benadryl IV or PO, and it has a very strong sedating effect on a lot of people, not everyone, but on a lot of people. And it also has quite high anticholinergic side effects. Now, first generation antihistamines are often used in cold preparations. What do you mean by cold preparations? I got nothing. How many of you have ever had a cold? What is the defining characteristic of a cold? Runny nose. What are those anticholinergic side effects again? Dry as a bone. So when you take Benadryl for a cold, it's not because it's an antihistamine. It's because it's also an anticholinergic. But Dr. Heyman, you didn't make me remember that under the anticholinergic drugs. Well, did you want me to give you another to memorize at that time? Okay, well, there you go. So when you're taking first-generation antihistamines for a cold, you're really targeting the anticholinergic effects. When you're using them to treat an allergy, then you're using the antihistamine effects. Does that make sense? So this is probably the number one used in the hospitals at this time. They often give it IV to patients who they think are going to have an hypersensitivity reaction. So for example, if you need an emergency x-ray with contrast, contrast sometimes causes an allergic reaction in patients who receive it. So to prevent them from having an allergic reaction, they would pre-dose them with Benadryl. Or if they started having one, they would give them Benadryl right after that. There's some others that are fairly common. So for example, doxylamine. Doxylamine is the active substance in NyQuil. How does NyQuil, how many have ever seen an advertisement for NyQuil? How do they advertise themselves? The sneezing, so you can sleep medicine, because the number one adverse effect is drowsiness. Another one is called hydroxyzine. And hydroxyzine used to be more common. It's less common nowadays, but it can be given for all the reasons Benadryl can, but it can also be used for patients who have anxiety. So that sedating effect also reduces anxiety. All right, second generation. So these include fexofenadine, which is better known as Allegra. And then we have loratadine, which is better known as Claritin. Then we have something called desloratadine, which is the active metabolite of loratadine, which is called Clarinex. Then we have cetirizine, which is better known as Zyrtec. Now, want to know something fun about Zyrtec? Hydroxyzine turns into Zyrtec in your body. What does that make cetirizine? Active metabolite. So hydroxyzine is the prodrug of cetirizine. Now, cetirizine has much less drowsiness than hydroxyzine. So if you want the antihistamine effect, you're better off taking Zyrtec. If you want the drowsiness effects, you're better off taking hydroxyzine. So hydroxyzine has the drowsiness and more anticholinergic effect. Cetirizine has less of that. So it's more appropriate if you're just treating allergies. Does that make sense? Now, what do all of these have in common? Less what? Less drowsiness, less anticholinergic effect. So if you have a cold, do you want to be taking Allegra or Claritin? If you have a cold, what do you want? You want a first generation. Does that make sense? All right, any questions about those? Oh, I should also mention that there's yet another drug called levocetirizine, which is the left hand of cetirizine. What do you mean by left hand, Dr. Heyman? Oh, I'm glad you asked. Take your hands like this. What do you see? They're the same. All right, now, take out a piece of paper and draw a hand turkey. It's a beautiful hand, isn't it? I don't think I've ever seen a better looking hand in my life. Now, take your other hand, try and put it in there. It doesn't fit. Why doesn't it fit? They're exactly the same. See? If they're the same, how come it doesn't fit? What's wrong with me? What's the answer? You were supposed to answer. I wouldn't have had to say that if you'd answered. Why doesn't it fit? Because they're symmetrical, but mirror images. You guys have never seen a mirror, have you? That was before your time. Okay. So, most drugs are what they call a racemic mixture, which means you've got left and right mirror images of the drug molecule. Typically, only one of them actually does anything. The other one just interferes or sometimes causes adverse effects. Sometimes the mirror image is toxic, so you can't even have it at all. So when they first made cetirizine, cetirizine was racemic. It had left and right hands together. And then we discovered only the left hand does something. So if you take out just the left-hand molecule, the levo part, and you get rid of the dextro part, the right-handed part, you have even less adverse effect and works even slightly better. So that's what levocetirizine is. Any questions about that? Welcome to stereochemistry. All right, you guys should have learned that in chemistry. Did you guys talk about that in chemistry? Did you take chemistry here? Yeah? You don't remember?
You probably heard the story of our chemistry.
Oh, you had a different chemistry class. Never mind. All right, enough said. But had you taken the normal chemistry here, you would have learned that. All right. Well, now we have one last class to go. And then we're going to do wound healing. We'll be all done. What time is it? 5 till 4? Oh, we don't have enough time. We might go slightly long. Okay. So, the important thing in here now is we're going to talk about steroid. You know what? Let's stop here. We'll talk about steroids next time. All right. So, last time we had just finished talking about a bunch of drugs, and we're about to get to the big one, steroids. So let's recap ever so quickly the different drugs. So the very first drugs we had were calcineurin inhibitors. Calcineurin is the precursor to interleukin-2. Interleukin-2 is the cytokine that is responsible for proliferation of T cells.
I don't think we went that far. We left on wound care. Yeah, we didn't do the wound.
Yeah, I know, but we were doing drugs.
Up to me.
Yeah, the hand.
What drug? Oh, hydro. Okay.
Yeah, we did all the drugs. This is recap. Except for steroids. So, how about if I just tell you the drug name, and then you'll say, oh yes, we did that.
Okay, how about
So, for calcineurin inhibitors, there are 2 of them. The first one is cyclosporin, and the second one is tacrolimus.
what is cyclosporin? What the heck was that? Prevention
Mm-hmm.
and autoimmune disease.
Do you see what I'm up against now?
Against gravis. I got you.
Yep. So, their main use for these drugs is transplant, but they are all used for some other things like Crohn's disease. You can use them for rheumatoid arthritis, etc. But the bottom line is they're immunosuppressants. They work by decreasing the number of T cells, and the number one adverse effect is going to be risk for infection. And in terms of etiology, if a patient has an infection while on one of these drugs, what would we consider that? What kind of etiology would that be? You're on an immunosuppressant, and then you get an infection. Iatrogenic. So. All right, then the next class of drugs was cytotoxic drugs. These are drugs that target all fast-growing cells. So in addition to T cells and B cells and neutrophils, it's also going to affect skin cells and other epithelial cells. It can also affect liver cells because liver regenerates fairly quickly. So the 3 drugs that we mentioned there, azathioprine, that's the one you'll need to know for your test, and then 2 others that are very commonly seen in practice are captoprene and methotrexate. Again, the number one adverse effect is going to be infection, and then you can also have skin side effects, hair loss side effects, because hair follicles are one of the fast-growing cells. You can have sores in the mouth. And those are all additional adverse effects. Oh, red blood cells. If it targets red blood cells, you'll have lower red blood cell count. And the fancy schmancy name for that is anemia. What's the fancy schmancy name for low white blood cell count? Leukopenia. And you could also have lower platelet counts, thrombocytopenia. All right, the third class that we did last time was biologics. Now, biologics is more of an approach than a true class of drug. So it's an antibody that is targeted against a single particular protein or substance. So most of the biologics that we have are targeted against TNF-alpha, so the tumor necrosis factor. And by targeting that, you lower the amount of TNF, which in turn is going to reduce the amount of inflammation present in the body. Same idea, if you're targeting an inflammatory mediator, you're going to lower the amount of inflammation. That puts your patient at risk for infection and a whole bunch of other stuff. And the drug name that we had said was like adalimumab, which is Humira. If you watch TV at all, chances are you'll see lots of commercials for Humira and other drugs that end in MAB. So remember that MAB stands for monoclonal antibody. And the reason that it's monoclonal is that the drug is full of antibodies that are exactly the same. So mono, one, clone. They're cloned off of one thing. So there's a number of different monoclonal antibody drugs that target various things, but in terms of inflammation, the number one thing they target most often is going to be TNF-alpha. All right, then we talked about antihistamines, first generation and second generation. What is the big difference between the two generations?
The first gen is older and it has more adverse effects.
First gen has more adverse effects. What are the two major types of adverse effects that they have? Drowsiness and anticholinergic effects. So if you're having a hard time staying up and you want to sleep, maybe you have a cold, which would be more appropriate, a first or a second generation? A first generation. Now, during the cold, is there lots of histamine being produced? So if you want to dry up your nose that's running, would you prefer a first generation or a second generation? A first generation, because you want those anticholinergic side effects to dry you up. Now, if what you have is just a regular old allergic reaction, what would be better to take typically? A second generation, because it will not be drowsy and it will not give you all of those other anticholinergic effects. On an elderly patient, what would be better? A second, because anticholinergic effects in elderly can mimic Alzheimer's disease. All right, so as far as drug names, we gave you the big one is diphenhydramine, which is also known as Benadryl. Very, very commonly used in the hospital IV when we have a patient who's going to be receiving some sort of drug that has a high risk of allergic reaction, or if we know they're already allergic to something, but there's no other choice, we have to give it to them anyway. So sometimes with like an imaging test, they're allergic to dye, the IV contrast. And so we know that they're going to have an allergic reaction. We'll pre-dose them with Benadryl first, then give them whatever it is they're allergic to. We also mentioned hydroxyzine, mostly because of its active metabolite, which is a second generation, cetirizine, Zyrtec. And then we also mentioned doxylamine, which is the active antihistamine in NyQuil. But for your test, the only one you need to know is diphenhydramine. Then the second generation, we had fexofenadine, Allegra, loratadine, Claritin, desloratadine, which is Clarinex, and it's the active metabolite of loratadine. So it works much faster than Claritin. Claritin takes about 3 hours to start working because your liver has to chop it up into desloratadine. So by giving desloratadine as the drug itself, it speeds it up and works a little bit better. You also don't need quite as high a dose because it's not being lost in the liver. And then the last one is cetirizine, which is Zyrtec. We mentioned where that comes from. And then we have the left versus the right hand of Zyrtec, which is levocetirizine, also known as Zysol. I do not know who comes up with these names. But one size, Zysol. That was terrible. Let's pretend like that didn't happen. All right, so at this moment, we're going to pick up with another drug class, and this is our last drug class for anti-inflammatories. How do you feel about that? Whew. No, Dr. Heyman, we want more. Okay, so this one is steroids. Now, when you think of the word steroid, what do you think of? Arnold Schwarzenegger. People with no necks. Now, that type of steroid is known as anabolic steroid and is drugs that stimulate testosterone receptors. Now, technically the word steroid means any substance that contains sterol in it, which, if you remember way back to your chemistry class, is just a structure of molecule. So you're probably most familiar with the term sterol in the term cholesterol. Cholesterol. Now, the word chole comes from bile. Cholera is another name for bile. So the bile duct is in your, well, the bile is produced in your liver, secreted into the bile duct, stored in the gallbladder. Gall is yet another name for bile. So many names. So bile, cholera, and gall are all the same thing, stored in the little gallbladder, and then when you eat a meal, and it squirts out. So the cholesterol that's being stored there, some of it is going to be secreted, but some of it helps to emulsify fats so that you can absorb them. So it got its name because we first found this sterol compound in the bile. That is just trivia. You don't need to know that for your test. But hey, you heard it. Can't erase it now. Now, some other famous sterols that you might want to know about. Estrogen. We already mentioned testosterone. But the one that we're talking about today is corticosteroid. Now, what does cortico imply? Where would it come from? A cortex? How many cortexes are you aware of in the body? Okay, the adrenal cortex, and what else? Prefrontal cortex. So it's either coming from your brain or it's coming from your adrenal glands. Which one do you think it is? The adrenal glands. All right. Now, time to see how much you paid attention in A and P2. What are the 5 hormones secreted by the adrenal gland? You should already epi and norepi, but that's from the medulla, not the cortex. 3 left from the cortex. That's pituitary. Renin is secreted by the renal kidneys. Aldosterone. Cortisol, and then sex hormones. If you're a man, then it's going to be estrogen. And if you're a woman, then it'll be testosterone. So your adrenal gland will produce the opposite of whatever you are. Everyone needs a little bit of both. And so your primary sex organs, ovaries for women, testicles for men, that is what produces your estrogen for women, testosterone for men. And then your adrenal gland will produce the opposite in some much smaller amounts. Does that make sense? So cortisol is actually what corticosteroids do. They activate cortisol receptors. Now, if you remember what cortisol does, one of the things it does is it raises blood sugar. So as a result, sometimes corticosteroids are called glucocorticoids. So the thing from the cortex that affects glucose. So you'll hear those terms used interchangeably, glucocorticoids and corticosteroids. They're the same thing. And they're drugs that activate what receptor? Cortisol. Okay, so let's just mention the drug names first, so that way we can talk about them as we go along. So they are ranked by potency. Now, what does the word potency mean? How much dose it takes to reach a certain level of efficacy. So the drugs that are more potent, you don't need as high a dose to get as strong an effect. So there's 6 drugs that we're going to learn at this time. And the first one is hydrocortisone. Now this is essentially artificial cortisol. And it's basically a 1-to-1 relationship. So it's 1 times as strong as cortisol, basically the same. Then, if we modify the hydrocortisone, take the hydro off, you end up with cortisone. Now, the thing about cortisone is that it can be given differently. It can be given PO, whereas hydrocortisone cannot be absorbed PO. It's also a 1-to-1 relationship. Next, we have prednisone and methylprednisolone. Prednisolone. All right, so methylprednisolone and prednisone are both approximately 4 to 5 times as potent as cortisol. In the hospital, methylprednisolone is going to be the one that you see the most often. It comes in 2 forms, oral and injection. The injectable version, well, the brand name for both of them is Medrol, but for the injectable version, it's called Solu-Medrol. Tell me what the Solu means. Solution? That's right. Now, there's a funny thing about Solu-Medrol. Once you put the drug into the water, or the saline, whatever you use to mix it with, it degrades fairly quickly and stops being effective. So, you're not going to get a vial of liquid. What are you going to get? A vial of powder that you have to what's called reconstitute. Now, the cool thing with our little technology is they have this little device that looks kind of like 2 vials on top of each other. So there's liquid in the top one and there's powder in the bottom one. And so what you do is you squeeze the 2 halves together, and there's a little stopper in the middle here that gets pushed down, and when that happens, the water mixes with the drug and you end up with the solution that you draw up. So you, as the nurse, are going to prepare this right before you actually inject it into the patient. Does that make sense? So, in the hospital, methylprednisolone is by far the most common one, general use and steroid. Prednisone is the most common oral one that you're going to see outpatient. So, in the community, people take prednisone more often, and in the hospital, they're going to take methylprednisolone more often.
So methylprednisolone is the one with powder.
Yeah. So methylprednisolone is the one that you have to reconstitute so you can inject it. And the brand name would be Solu-Medrol. All right, then we have 2 more to go, and these are 20 to 30 times stronger, or more potent, I should say, than cortisol. And the first one is dexamethasone. And then the last one is same thing, and it's called beta-methasone. Now, what has this whole unit been on? What's the major topic of the unit? No, that's the drug we're talking about. The whole unit we've been talking about for like the last 3 hours. Inflammation. So these drugs do what? Reduce inflammation. So the purpose of these is to reduce inflammation. Dexamethasone is kind of like a general purpose, really strong one. Most often you're going to see it used in cancer patients, but sometimes you'll see it used in other settings as well. Beta-methasone the main place you're going to see it in the hospital is labor and delivery. And one of the functions of cortisol, now cortisol is considered a stress hormone, if you recall way back from ANP2. So when you have large amounts of stress, you get large amounts of cortisol being released. Now, in a little fetus's life, what do you think is the most stressful thing that happens to that little guy before he's born?
Like when the water breaks out.
Being squeezed through a little birth canal? Have you seen a little baby after it's born that way? What does its head look like? Cone head, right? Do you think that's a little stressful?
Yeah.
And what about this process, like where the cervix is like grows, and as that happens, there's these contractions, and the baby's like, that's a little stressful, right? So during the birthing process, large amounts of cortisol are going to be released, maturing that little guy's lungs. Because up until now, he's been breathing water. Just like in the movie The Abyss. Before your time, don't worry about it. So at this point, though, the little guy's got to grow lungs that finally work and breathe air. Up until this point, his lungs have not matured because he hasn't had a need to have them inflated with air. Now he's got to survive outside the mother's womb, got to take that first breath. So in order to do that, we have to mature the lung. The final maturation of the lung is driven by cortisol. So if you have a premature child, you know, the premature labor, where the woman's going to deliver the baby earlier than expected, one of the things you want to do is you want to mature that little guy's lungs, or girl's lungs, before they are delivered. And the way we do that is we administer betamethasone to who? To the mother. That you do this before the kid is born, not afterwards. It's too late after that. So, putting all the drugs we've learned together about premature labor, if we want to stop the premature labor from happening, what drug, or try to stop it anyway, what drug do we use? What drug? Terbutaline. Well, what if it doesn't work? Now the kid's going to be born. We want to make sure he's got a mature lung, so what do? Give betamethasone. To whom? To the mother. So that's the major place you're going to see betamethasone. Now, you will see both betamethasone and dexamethasone used outpatient as topical preparations, ointments and creams. But inside the hospital, inpatient, cancer is probably the number one place you're going to see dexa, and then labor and delivery for beta. Most of the rest of the time, what you're going to be seeing is oral prednisone and IV methylprednisolone. There is a specific time frame, and because this is not a labor and delivery class, we don't care. You can look it up on your own. I'm sure it's in the book. Well, I mean, I don't care. Maybe you care. But I've seen more than enough deliveries in my lifetime. I'm kind of done with that phase of my life now. But anyway, so these are the 6 drugs that you're going to need to know for the test. We'll be learning a few more as we go along. So for example, there's inhaled steroids we use for inflammatory lung diseases, and we'll learn those when we do respiratory. But for now, what we need to know is these 6. And we need to know how strong each one is, and some general things about each one, which we just talked about. Now, hydrocortisone, I've got to mention this before we end. Hydrocortisone is available over the counter. And that means it's the number one most seen or most used in the whole world, or in the United States anyway. But in terms of oral, it's prednisone. So don't get that mixed up on the test. The most common, generally speaking, is hydrocortisone because you can get over the counter, but it's topical. Creams, ointments, suppositories. The most common PO is going to be prednisone. All right, so now let's talk about what the drug does and some adverse effects from the drug. So the number one thing that we want the drug to do is going to be what? Reduce inflammation. So you're going to need much, much higher doses than normal. There is a disease we'll learn about in Pathopharm 2 where a person doesn't have enough cortisol production. And you give cortisone PO for that. But that's not the subject of now. The subject of now is using these drugs to treat inflammation. So we're using much higher doses than physiological doses. So at physiological doses, cortisol does things like it raises glucose levels, it raises sodium levels, and it raises blood pressure by raising sodium levels. It's going to affect protein metabolism and fat metabolism. It increases hunger. And deals with a couple other electrolytes, the most important of which is calcium. All right, so these are the big ones. Now, in addition to all of that, it also deals with inflammation. Now, what are we targeting in this unit? We're targeting inflammation. So everything else is a potential adverse effect. Does that make sense? So this is what we want, reduce inflammation. And this is what we're going to get in addition. Now, some of these are important short term. Sometimes you only take these drugs for a day or a week. But sometimes you take these drugs for life. And so some of these adverse effects are going to be more important for acute, and some are going to be more important for chronic. Does that make sense? So, adverse effect number 1. What happens when your blood sugar goes up? Okay, it mimics diabetes. So it can actually be a cause of diabetes. What's the fancy name for blood sugar high? Hyperglycemia. Elevated sodium. So we call that hypernatremia. But what's important is that it will lead to elevated blood pressure. So high blood pressure. If you've got a patient who's already got high blood pressure, could that be a problem? Yeah, it can be a problem. These things are relatively short acting, so they'll be a concern from the moment the patient takes the drug. Potentially, anyway. Protein metabolism. The main thing it does is it prevents reduces protein anabolic pathways, which promotes protein catabolism. What does catabolism mean? Well, if you're a bodybuilder, what effect do you want? Anabolic or catabolic? Anabolic, big, grow. Catabolic, break down. So if we're breaking down proteins, that's going to be protein catabolism. So 3 really important things for protein catabolism. First one is muscle wasting. Patients who are on chronic steroids tend to have lower muscle mass. Yeah, it gets atrophy and smaller muscles. So they tend to have muscle wasting. Second one is, what's the protein in your skin called that provides strength? Keratin? No, that provides the waterproofing. And there's another one that produces the elastic effect. What's that one called? Elastin, that was easy. And the third one is sometimes injected into people's lips. Collagen. So the decreased collagen in the skin leads to weaker skin. So patients who have weaker skin are more likely to have skin tears or other wounds. it can get to the point where the skin is so fragile that we call it tissue paper skin because it tears as easily as tissue paper. Now, that's really, really important as nurses because if you're taking a patient and you're moving them, you go into a patient's room and they're like all slumped in bed. Oh, I got to pull you back up in bed. You can't slide them. You've got to lift and, that makes sense? So you have to be very, very careful. Even just taking a blood pressure, you can break their skin if you're not careful. So that is tissue paper skin from loss of collagen. And then the third one is also a collagen issue, and then combined with the decreased inflammation, which is decreased wound healing. So the patients will not be able to heal as well. We haven't covered wound healing just yet, but I'll give you a little quick preview. You have to create a scar tissue. And the scar tissue is a protein matrix formed of collagen. Same stuff that provides the strength in your skin is what provides scar tissue. If you can't make that scar tissue in the first place, it's much, much harder to heal. And then on top of that, remember, inflammation is one of its purposes is to prepare the body for repair. And if you can't do that as well because you're suppressing it, decreased wound healing is the result. So all of these three things are a result of protein catabolism. Now, fat metabolism problems, there tends to be a redistribution of fat. So these are sometimes called lipid dystrophies. Dys meaning bad or wrong, and trophy meaning shape. So the three places it's going to tend to redistribute. First one is the back of the neck. This is called buffalo hump. I didn't make it up. So there's a fat pad right here at the base of the neck. The next one is to the face, and this is called moon face. So people who have this effect, they'll have these like very round faces. If you just Google moon face or Siri moon face, you'll see pictures of exactly. Once you see it, you're like, oh, steroid person, you're on steroids. It's very noticeable, that kind of appearance. And then the third one is central adiposity, which is a fancy way of saying you get redistribution to your midsection. Now, women, because of estrogen, tend to store fat where? Hips and buttocks. But when you're under the influence of elevated levels of cortisol or cortisol-type drugs, you end up having it in the belly. Now, when you combine central adiposity with muscle wasting, you have a classic appearance known as toothpicks on a lemon. Yeah, I had a friend who had a lung transplant, and to prevent rejection, she had been on steroids for 15 years. And she went to this new doctor, and he's like, oh, you're on steroids, you got toothpick on a lemon. I think he was actually telling the medical students that, look, everybody, she has toothpicks on a lemon. So that is the three things that tend to happen. So to prevent these things from happening, one of the things you want to do is make sure your patient's eating adequate protein. And the second thing we want to do is promote muscle synthesis by having them exercise. And then the third thing we want to do is we want to limit the overall calories, which can be difficult because what does cortisol do? It promotes hunger, and it also makes food taste better. I had a boss once who had been on steroids for some reason or other, and she's like, we would go out to eat, and it'd be like the most ordinary hamburger in the whole world. We're like, have you ever tasted a hamburger this good before? So anyway, that can be an issue. So you want to have the person track their calories and not overeat. And then the last one is, I should mention this. Patients who are on these drugs because of the increased sodium, increased water retention, will make their weight go up even if they keep their calories under control. So they might appear overweight even if they're not, just from that water retention. All right, as far as the electrolyte goes, we already mentioned sodium, but for calcium, the big thing here is what happens if you don't have enough calcium in your bones? What's that called? Brittle bones, what is it called? Little holes in your bones? Osteoporosis. So they are at increased risk for fractures. But it's not just, well, if you fall, you might break your hip. It's just standing around, you can shatter the vertebrae in your back. Now, have you ever seen someone who has a posture that just all of the time, and all you want to do is you're like, just straighten you out. There you go, better. And I'm not talking about just bad posture. I'm talking about like, and as it turns out, a lot of times those patients can't, because if they've had vertebrae fracture, instead of little stacked vertebrae like this, they have little wedge vertebrae. What's happening to the patient's spine? You see the difference? So if they have compression fractures, that is going to cause kyphosis, but also lordosis. My wife's grandmother, when she died, they lose height, and they lose height because their spine is now curved like that. So I thought that she had a deformity of her scapula. It turned out that that was her spine. So her thoracic spine was over here. Now let's just simulate that for a moment. Everyone round your shoulders forward as much as you can and hunch like this. And now take a deep breath. Is it easy to breathe like that? No. So patients who have this are at risk for two things. One, decreased ability to breathe. We'll talk about that for the next test. And then the second one is chronic pain. Because what comes off of your spinal cord? Nerves. And if those nerves are being impinged by the mechanical deviation of your spine, that can lead to chronic pain. So they lose height, they have deformity of the spine, leading to potential chronic pain, increased risk for pneumonia because they can't breathe as well. If they already have a lung problem, like asthma or COPD, it's going to make that worse. And then it also puts them at risk for fractures if they fall. So it's not just, okay, try not to fall. There's more to it than that.
So my friend, she had like PCOS, and they gave her steroid, and she has like literally every single one of those. And she has like sclerosis. Is there anything you do for it? Because she even has like this blue face.
Polycystic ovary syndrome is a really interesting thing. They tend to have more testosterone than the average woman, sometimes like 2 to 3 times as much, which makes them really good athletes. But it also causes a number of other problems. And so to fix that, sometimes they'll give them steroids, or sometimes they'll give them birth control pills to try and suppress the testosterone production. But yeah, when you're on chronic steroids, you get these things.
Because they gave it to her once, and she's never been able to like unblow everything. It was just like, I was just wondering if there was a big
So she hasn't been on that in like a while?
No, she got it when she was 14. She like had to go to the hospital because she almost like passed out, and they gave it to her, and she's like 20 now, and she's still like 11 with like little things.
Yeah. She needs to do strength workouts, eat enough protein, and track her calories. Yeah, but I mean, yeah, once you have that shape, it's a hard road to get back to normal. All right, but wait, there's more. We also have to add in one more down here, which comes out of nowhere, which is cataracts. So cataracts are not related to protein metabolism. They're just an opacity of the lens. And it just comes out of nowhere. But patients who are on steroids tend to have more cataracts. That's going to make their vision dim and blurry. And the only cure for it is to give them a cornea transplant, at least at this time. You can surgically remove them, but sometimes, depending on how bad it is, they'll need a cornea transplant. Oh, that's a lot of stuff. For just one little drug. So steroids are no joke. The other thing about steroids is the way that they're made. So your body doesn't store cortisol in the adrenal gland for later use. It produces it as it needs it and secretes it at that time. So if you remember back to ANP2, there's a little thing in your brain called a hypothalamus. And that releases a little something that goes down to a little gland. What's that gland called? The pituitary gland. And then that secretes something called adrenocorticotropic hormone, or ACTH. That goes down to your adrenal gland and tells your adrenal gland produce cortisol. High levels of cortisol go back up to your pituitary and say, well, cool, man, we got the message. And then that lowers the dose of ACTH, the level of ACTH. And then that tells your adrenal gland, don't produce as much. So that's a negative feedback loop. The more cortisol you produce, the less ACTH you have, which then tells the adrenal gland, it's okay, you don't need to produce as much. So what do you think happens when you give a drug that is essentially mega doses of cortisol? What happens to the level of ACTH being produced by your pituitary? It goes to 0. So what does that do to the cortisol production in your adrenal gland? It goes to 0 too. It goes to 0 too. No, you say it. It goes to 0 too, right. So imagine for a moment that you've been taking one of these drugs for a week or 3, and how much adrenocorticotropic hormone does your body have right now? Not a lot. How much cortisol is your body producing? Not a lot, maybe none. So now all of a sudden you stop taking the drug, and what happens? You have no cortisol production whatsoever, and you go into a condition called adrenal crisis, acute adrenal crisis. And basically, you get the opposite of all these things. So instead of high blood sugar, what do you get? Low blood sugar. Instead of high sodium, what do you get? Low sodium. Instead of high blood pressure, what do you get? Low blood pressure. And your patient can die from that low blood pressure. So what do you think we might do about that? Well, okay, we're going to put them back on a steroid, and then we're going to gradually decrease the dose. And what's a fancy name for gradually decrease the dose? Taper. So going back to methylprednisolone, in the oral form, there's something called a Medrol dose pack. So when you get that little pack, it's a little foil thing, and it's got little, they call them blister packs. So they're labeled. So how many pills do you take on day 1? 5. How many do you take on day 2? 3? 4? Yeah. So you can see that the number is going down until you get down to 1. So this is a self-tapering prescription. Does that make sense? Yeah. So that's only used for a short-term thing, but you still use that principle anytime a patient's been on steroids for a significant amount of time. You don't withdraw them acutely, you taper them down. And that's to avoid what problem? Acute adrenal crisis. Okay. Yeah, acute adrenal crisis. All right, the last thing we need to mention is that there's a difference between normal dose and super high dose. So for example, methylprednisolone. One of the very most common things that you're going to see methylprednisolone used for is COPD. So COPD is an inflammatory disease in the lungs leading to chronic bronchitis and emphysema. Patients come in with what they call an exacerbation of that. They've got nasty, gross sputum and just not doing very well, and we need to get their inflammation under control really quickly. So we give them either IM or IV methylprednisolone. And the dose of that is typically going to be something like 40 to 60 grams, and you might give that 3 times to 4 times a day. So what would the total dose be if you're giving it, say, 4 times a day? I know this higher math is hard.
1600 to 2400.
No.
4 times
What's 4 times 40?
160.
160. You said 1600.
Oh.
Yeah.
Yeah.
All right. So you're going to give over the course of a day maybe up to 240 milligrams, and that would be considered a very high dose. Now, if a patient is having transplant rejection, then they could be having 1,000 milligrams IV at once. When you're giving those mega high doses, you're no longer suppressing inflammation, you're suppressing immunity. And the super high dose of steroid will actually kill T cells. And so it's not just suppressing now, it's actually destroying existing immune response. That also makes it so that we can use these drugs in cancers of the white blood cells. So if you have a leukemia that is lymphocytic, where you've got large numbers of T cells being produced, you can actually use steroids to treat that type of cancer. All right, any questions about steroids? It's a big topic. There's lots to know about it. You just got to know about it. You're talking about, what kind of drugs do you see all the time? You're going to see methylprednisolone all the time. Any other questions? Okay, you didn't actually ask a question. I just assumed it. All right. On that note, let's move on to our next topic. And I think the only topic that we have left was wound healing. Is that right? All right. So wound healing. We said early on that the purposes of inflammation, one of them was to prepare the body for wound healing. And that's the last thing we have to talk about. All right, so let's imagine for a moment 2 different kinds of wounds. In the first one, the patient goes into the hospital and the doctor uses a very, very, very sharp instrument, cuts into them, and now you've got very clean edges and you've got a very clean wound because they disinfected the skin first, or whatever you call it. Not disinfect. You can't disinfect skin. Say again? Antisepticized? Sterilized. It's not really sterile because you can't sterilize skin. But anyway, whatever. You prep their skin. So there's fewer bugs on it, really clean wound, nice edges, and then you close those together with something. What something could we close those together with? Okay, so stitches, we're going to call those sutures. What else? Staples. Say again? Glue. Steri strips. So tape. All right, but in some way, we're going to join these edges together, right? Where do you think how does the healing go? Well, it's going to go from both directions. Now, what do you think the advantages of this are? Is it going to be faster or slower than if you leave the wound open? It's going to be faster. Are you going to have a bigger or larger scar? Say bigger or larger. Bigger or smaller scar? Yeah. Heads I win, tails you lose. So it's going to be a smaller scar. What about risk for infection? Smaller because the skin is closed, so it's acting as a barrier. So those are some of the advantages of primary intention is what it's called. So primary intention. Now what's the downside of primary intention, or what are some potential complications? What if we close up something else inside here? Leave behind a surgical gauze. They call, by the way, gauze in the OR, they call them sponges. So the first time you go in there, like, how many sponges do we have? And you're like, I don't see any sponges at all. It's not gauze. Okay. So maybe you leave a gauze sponge in there or something else. You've got a source of potential infection. So one of the downsides of these is if you leave something in there, it's more likely to cause a problem. Second issue is you can't close the wound after a certain amount of time. And that's typically going to be about 8 hours. So if the wound has been open for longer than 8 hours, the risk of infection is so high that when you close it up, you could be making the infection worse. So if you cut yourself and you're like, I'll go to the emergency room later, yeah, it might be too late for them to close, and then you'll have to heal the other way. So what do you think the other way is called? Secondary. So in this case, we have not closed the wound. What's the only possible way for this to heal? It's from the bottom up. So it's going to be slower, a lot slower. There's going to be much larger scar, higher risk of infection. But depending on the type of wound, sometimes the only choice is secondary intention. All right, any questions about wound healing? There's stages. Oh, sorry, I guess I should talk about that too. So it's generally speaking a three-step process. The first step is called regeneration. You have to regenerate functional tissue. Second step is called scarification. So you have to build a scar, that network of connective tissue, which is collagen. And then the third step, you actually destroy the inflammatory components that were there helping to repair the tissue. So if you've ever cut yourself, you probably notice that as it heals, the area is slightly pinker than usual because there's more blood flow to the area. But then eventually that goes away, and what you're left with, at least in a lighter skinned person, is a white scar. And the reason for that is that after the wound is completely healed, that extra blood vessels were destroyed, and you don't have that excess blood flow to that area anymore, leading to a pale line. In the case of a darker skinned person, it's usually a darker line. And that's pretty much it for wound healing. We're not going to go over the stages of cell growth. You can read about that on your own, and it's not going to be on your test. So, on that note, we are done with inflammation. One of the biggest topics for Pathopharm 1. The only topic that might be bigger is respiratory.